Hi, this is Nancy Nevin-Folino, and I am a registered dietitian at Dayton Children's in Dayton, Ohio, and I've been in this field for over 30 years, trained at Dayton Children's. I work with a medical team my entire pediatric career. I've also been very active in the Academy, which is the Association for Dietitians, and have specialized in peds my whole career. And what you are probably experiencing and what I've experienced from the beginning is that many times we have one-of-a-kind patients. So what I'm going to talk about today is complicated eating issues related to this area of pediatric treatment. I did say that I work with a team, and this is very important for interconnection of specialists to devise a plan for patients that have individual problems and measure the success. Sometimes in your state, with the state health department, teams have been institution and state driven with guidelines, and actually in Ohio for a period of time it was within the health department regulations. And we also have to look at outcome results now with insurance and cost for therapy and treatment. We have infants that have different degrees of issues, and as they get older, sometimes there's an increase of developmental issues. I have always worked with a hospital team, but in many areas there's private practice teams and also health department driven teams. We are experiencing a very high level of drug use in our mothers, and this presents prenatal and postnatal issues and treatment, and it also has really individualized, increased the need for individualized therapy. I'm not sure where you are located in the United States, but even in Ohio, we're dealing with telemedicine, and many specialists are involved in that because the rural areas may have a doctor, may have a pediatrician, but as far as specialists, including medical physician specialists and therapy specialists, they are not to be found. And then I'll talk a little bit about how important it is to have electronic medical record section for the team so that anyone on the outside or the inside can locate that, so that at any given time, say in the ED at 1 o'clock in the morning, that's accessible so that the team knows what is being done with the patient and the success and timeline. Now, I really do believe in a team. Like I said, I started with a team, and we have added disciplines. I was responsible myself for actually bringing occupational therapy and speech into my NICU because the Ohio Department of Health stated that in our follow-up clinics for high-risk infants, we had to have a developmentalist or occupational therapist, we had to have a speech pathologist, we had to have a dietitian, and a neonatologist. So we had guidelines by law what we could do, but I suggest that for treatment. And then we have to individualize each plan because, as you know, if you work with this area of patients, everyone is different. In the early days when we were saving 26-weekers, 27-weekers with multiple problems, we didn't have any guidelines. Now there's guidelines in all areas of treatment, but again, it's the combination that a patient has that requires an individualized plan. And then team evaluation of initial and ongoing, when you're going to see this patient and how you're going to follow up, not only individually as a therapist, but also as a team. And this is very, very important and is the key to success, having the family, caregiver, and patient evaluation and needs stated. And as you know, sometimes you're talking to the mom, but grandma's the babysitter and no one has any idea what the grandma's doing. Or in this day and age, they may have a daycare center for some of these children that have individualized needs as well. Therapy needs to be organized and scheduled, who and what, when they're seen. Sometimes when I was working with our follow-up team for the state, I would need to see the patient every 4 months, but other therapists did, and vice versa. And then a well-stated follow-up and monitoring, what you want for this patient is stated so that the team can follow that. Now, it is very important to have a consistent approach in delivery, even though you're individually designing the plan. Family-friendly is pretty much evident that you need to do that so that you're helping them, and patient-specific based on the condition and medical status. Global plan with timeframes and desired outcomes. Now, like I said, if you treat this population, sometimes we don't know, but to plan is better to have timeframes and desired outcomes by each one of the fields. So if you're seeing this patient as, like myself, as a dietitian because weight gain hasn't been good, and then we realize that the weight gain hasn't been good because the baby is not orally eating well, that has to be planned into things as well. Scheduled follow-up so that the family knows what's happening and is ready to be involved as well. Adjustments to the plan. I have prescribed formulas before and the family calls and said the baby won't drink it, or baby's having constipation or diarrhea, so adjustments to the plan in every discipline. And then team and family input. I've actually had parents call me within a week and say, I'm not having success with this at home, so we have to change what we set out at discharge. Now, the nutritional health, of course, nutrition, you can't have health and you can't have growth unless you have nutrition, which is a good thing for dietitians and employment as a sidebar. But close monitoring of nutrition and growth, especially for the first 5 years of a child's life, is very important because it will map out how this patient will progress in life. We are now having electronic medical records that give us a BMI, which is very important. I don't want you to feel like you have to be locked into that BMI, but many of you that have practiced for 10 years or more know that we've made short fat babies, short fat patients, so that you can't just pack on calories to get growth. You have to have growth as well as length. And it's difficult to decide about calorie needs, and I'll probably go into this further. We've had to lower some of our expectations where the RDA, the recommended dietary allowance calories for a 6-month-old is about 105 calories, and we've had to lower that to 80 calories per kilogram because baby's just getting so huge. And I'll cover this later in the presentation. Nutrition development for gestational age, feeding modality, how that works, exposure to texture and flavor. This cannot be ignored. We used to, in the old days, wait till we thought the patient that was older, and we were using the expectations of normal child development for a severely handicapped individual. And so now texture and flavor for any of those that are out there that do this, just smell and tongue exposure and lip exposure to flavors. And it's so fun to watch these babies in the intensive care unit when they're exposed to different flavors. And this should be led by the responsible team member that does this. And dental evaluations at appropriate corrected age. We are actually having babies stay in our NICU for longer periods of time just because of the way the care provision is given. And we have babies that get teeth and we have to brush them. And I'm the one that says get out the toothbrush because, and everybody looks at me like I'm crazy, but this is very important to understand for healthcare. Now, I believe that in a team, you want somebody leading, and sometimes I've been the leader because there's not too much of an issue on any of the other developmental parameters except for growth, so I sometimes lead those patients, and it's per your team composition, I have had periods of time where our social worker in our follow-up clinic was very instrumental in being the lead person. I've also worked with a team where the occupational therapist was the lead as far as scheduling appointments and looking to individual issues. Sometimes patients have just one big concern and they're followed by that therapist more often than the team, and it makes sense to use that team person as the leader for this patient because they're seeing them more often. And the job duties of a team leader, like I said, is follow patient issues to evaluate care delivery and process how often the family needs to be seen, and to interact and guide the family with their services and to put them in touch with whoever can handle and guide them on a problem. Follow-up is done based on the patient's care needs. And we do have patients that graduate and have a party for them when they're at that period of time when they graduate. And everyone's excited. It's very similar to high school graduation as far as in degree and happiness. And then schedule care conferences for update and plan is a team leader responsibility. And again, this can't be done individually, so I have known people that have set out to start their own team because they're seeing a certain client load that they need others involved, and they're having to piecemeal therapy together, where a team approach and a leader to direct the families are always good. Now, one of the things that happens to us therapists, especially in a hospital-based, not necessarily so much public-based, public health-based, but is that you don't see what happens outside unless you have home visits. So this should be considered based on the family and the patient condition and the resources. Out in the hinterlands, we have used the public health department and communication for home visits, safe water supply. For those of you that many of your patients are on WIC and they're using powdered formula, this is very important, especially in impoverished areas in large cities, whether they have a safe water supply. And then if the house is a non-toxic situation, I know in my early days when I worked for WIC, we lived in a neighborhood that had many houses that were condemned because of the lead paint. And this is an old problem, but some of you that are in established huge cities know this to be an issue. The number of the caregivers who needs to be trained. I myself have got into a problem with this before where I'm giving mom and dad instructions and it's the grandma that's with the baby all day long, and she didn't hear the health plan and she didn't hear the concerns, and by God it worked for her kids, so she's doing what worked for her kids. And then safety for personal health and patient. Those of you that live in big metropolitan cities, even crime is an issue for safety for patients. This would be someone you would contact outside the team and probably the public health department. Physical limitations, stairs, what the parents understand as far as conditions and living situations that the child needs. And transportation is a huge issue. I have some patients that have come to me before, an outpatient, where they've had to do 3 bus transfers with an ex-preemie in a stroller with equipment. So it's not an easy thing for some of our families. Long-term growth needs. I feel, of course, being the dietitian, I feel this is important for the whole team to see. Many times we'll have a baby that's born even as young as, or even as old as, I should say, in today's terms for gestational survival, is that really even at a 30-week gestational age baby, it's not important for them to follow the growth curves of the growth chart. It's important for them to follow a curve. Many times we've had to adjust our evaluation as far as how the patient should be done, but this should be discussed as a team as far as long-term growth needs and where this patient's going. I'm sure a lot of you have been involved with patients where you've had to use higher calorie formula, which is less water added to the formula, but my feeling and overall growth evaluation is that protein is the main growth nutrient. And so if you're adding other things to add calories, such as carbohydrate or fat base, you have to keep your protein percent the same. And this would be a discussion with the dietitian on your team to make sure that that happens. When you concentrate a formula, your percentages are staying the same, but the osmolality is changing, which could affect bathroom issues and heart issues because of the digestive stress. The emphasis for these babies and children with handicaps is to emphasize on overall growth and individual growth, not just weight gain. And I've had to stress that greatly in the NICU because we'll have very challenged babies for length, but they're at the 97th percentile for their weight, which gives them a BMI of 120%. So we haven't really done anything, and we may be even stressing the infant more by having them overweight for how their linear growth status has been. Bone status, one of the things that you do that you need to help your bones develop is weight bearing. And an infant that lays in a bed for 4 months or so doesn't have much variation in how their bones are supported. So this is talked with the occupational therapist as far as movement and upright position for babies that are even in the NICU in the beds, or so this needs to be watched and discussed. And catch-up growth must be individualized, and I can't tell you again how many children have probably come out of NICUs in the country that are short and overweight because we gave them many extra calories, but we did not attend to their linear growth. And then reasonable growth curve overall. And this is a team decision, and really sometimes if you're going to have altered growth expectations, it should be stated. The family should know this. It should be in the medical record so that everyone knows what you're expecting. And again, here we're talking a little bit about evaluating growth status. With children with medical issues which affect growth, it's just almost better to follow the patient's own curve definition. As you see here in this growth chart, you see a progression on the chart, and this is based on the population, not individuals, so that an individual plot, you shouldn't be like everyone downtown, and that's sort of a joke, but anyway, so you're going to look at linear growth and following a curve definition that the growth charts do, and correct for prematurity until at a minimum of 1 year of life or until infant has established their own growth curve. This should all be discussions with the team because many factors are involved with this. And again, with the BMI as an indicator of body mass adequacy, this helps also so that you don't make a baby overweight for their linear progress. Now, feeding modality, I'm sure you don't have very many infants in the NICU that do this, that have a big slice of summer watermelon to sink their teeth into, but anyway, it should be patient-specific. The speech pathologist is the one that helps us and actually states her plan in the chart so that it's followed by the team. It's all developmental and gestational age appropriate. Also skill development appropriate because we have different conditions that patients have. If they've had grade 3 or grade 4 bleeds in the IVH, they may not development according to what their gestational age is appropriate. So again, this is a team plan. Where do you want to see them? How do you want to see them progress? As soon as, well, actually before teeth come in through the gums, you need to have a dental health plan for the family and for the baby. For those of you that have had babies in your NICU or intensive care for months, they aren't always seeing regular or having dental evaluations. So this is something that really needs to be discussed and looked at. And then stage therapy involving the team for feeding so that everyone's aware of what the feeding plan is and so that they can progress and help. Now, modifying texture and recipe per patient and nutrient needs. Again, this is all individualized. Many of the times that I've been working with my team, sometimes we're just sitting, scratching our heads and saying, well, what about this? Or how about if we do this? Or how about if we do that? Most of the time, patients that are on gastrostomy tubes, they're using a formula that's well-based, and although this shouldn't be overlooked for dental health and or taste sensitivity based on the condition of the baby. We have had babies that are underweight, they're so little, and we pack them with calories and they don't gain, and then we have babies now that are getting overweight because our nutrition is so much better and so more immediate than it used to be even 10 years ago. So this all needs to be looked at for modifying texture, especially for babies that have been on NG tubes or have G tubes. The development of this texture issue and texture exposure should be well developed in the plan. Sometimes we have lab abnormalities and we have to add things or stress certain types of nutrients for nutriture, and sometimes we've added electrolytes actually into the feed, but this is dicey as well because it can alter how the food is metabolized, and it can alter the delivery process of the food. So this, again, it needs to be team discussed. Allergies and sensitivities, we're very fortunate that we have many options as far as formula choices, but when you're introducing food, sometimes this is a problem and has to be discussed. The availability of texture products and family resources, and then at the last, safety and sterility. You see I have two blenders here. Well, let me tell you, blenders are the biggest source of germs there ever has been if they have not been cleaned and or sterilized properly. So this all needs to be discussed, especially if the family's doing this at home. Monitoring, we, again, this is based on the patient. What you're looking for as far as nutrition is GI tolerance and functionality is foremost. And when I say functionality, so if you have a baby that's on G-tube feed, someone's always got to be looking ahead, like when are we introducing solids, when are we giving them taste exposures, et cetera, et cetera. And then the advancement of feeding modality needs to be with family input, and so they're aware of the plan. And again, I caution you that the family plan should be for every caregiver that's in the community that treats or that helps this infant, so it's not just mom and dad that know, but the family knows. Most of their follow-up and their coordination needs to be done with allied health and therapy so that there's a map of who sees who, and this is what I we'll be talking about this in a little bit. And growth and developmental expectations clearly noted and shared with all caregivers so that the physicians, the home physicians not doing one thing and the team's doing something else. This is intuitive, of course. We all have patients that go backwards, which is a sigh for the team and actually sometimes sad for the team. Really be involved in making adjustments and develop an action plan to handle the change, so it's not like one nurse is doing one approach and someone else is doing something else, or the speech pathologist is working on introduction of one thing and the intuitive, but it's a good idea so that when there is a setback, a plan. I've had babies that I've sent home on a mixture of formulas and they couldn't get one formula, so that was failure of the plan. Or after an illness or a cold, they don't tolerate the nutrition plan, any variety of different kinds of failure for treatment. And then this should all be discussed in context of the overall long-term goals and always heading and looking forward. So we're making this change now. When should we set our evaluation for update, increase in ability from that plan, from that time on, and also for goals for the family where you're looking so they're not trying to push the kid ahead of the schedule or change things at home. So the best thing to do when there's been an alteration in the plan is discuss this with the team and the family. What is it we can do, continue to do? What is it we need to change or modify? Where are our goals, and when do we think we're going to try to get back to where we were, and set these time frames and evaluation. This also helps as far as who's the follow-up person and who sees this person to monitor to make sure that the patient is doing what you set out or want to, or going back to normal. Now, we all have patients that have unexpected illness, and sometimes in the NICU, it's not always a good illness that requires surgery, and you really need to have a whole team input for this. If they have been outpatient and now are inpatient for whatever illness has occurred, again, a team input meeting. Many times, if you're out in the hinterlands phone calls are fine too. A phone conference is a good idea also, just so everyone knows what's going on, and to use as much of the patient's personal plan as possible. This helps the family stabilize as well, so you aren't changing a whole bunch of things at one time. And then discuss the steps for getting on track so everyone knows the plan, and assist the family with what's going on and supplies and how they're going to be followed up. And any of you that work in the NICU, I'm sure you have had this happen to you, where you have a baby born at 28 weeks gestations, and the parents are asking at 32 weeks, when can we go home? When can we go home? So it's always a good idea, well, we have to do this first and then this, and we have to look forward to this, and it just helps them as well, so it doesn't seem unending. And then as far as an unexpected illness, get right in there and decide on who needs to see them, and update the meetings with the team as far as who's going to follow and who's taking care of this, and put a note in the chart. Advancement for nutrition, of course. You can't grow unless you have increased nutrition. So medical nutrition therapy should be advanced for growth expectation on all patients. This is real important for families to know if they have a baby at home on tube feeds, as to how often to change the rate. So this is intuitive. However, if you have a family that tends to act on their own, you want to make sure that if it's deleterious to the patient's health to advance too quickly, that they need to follow a certain increase back to normal, a pattern of increase, so that they don't set the child back. And then consider a standardized checkoff to be used when team plan method is put into place with dates, so everybody's kind of on the same page. If you're in contact with everybody all the time and you work in the same office, that's one thing. But when you have people at different institutions, or your speech therapist is through the county and the dietitian is through the county and other caregivers are at the hospital, you can understand where this would be really important to have a checkoff so you know what's happening. And then make an assertive plan to get better, so that they aren't left in limbo, and consider, like I said, mapping out a calendar for achievement expectations for the family, broken down into steps for the family. And this really is probably for patients that have multiple issues in multiple areas where they're being treated. Now, every once in a while, we'll get a situation where we've had the NICU team involved with a patient, or et cetera, and another discipline has to be added, and it would be a good idea, especially if this patient's involved, to have the team leader have a phone call or a meeting to delineate the treatment that's done so far and the health of this child, and then have the new professional meet with the team, even if this has to be by phone call, so that he can ask the team questions and the team can ask him questions, and explain what suggested therapy plan outcome is expected. So I'm just going to give you an example here. We've had patients before where we've been treating them for over a year, and all of a sudden a cancer will show up, and so this is going to be a long involved treatment with another team, and so this is really important that there's communication out there from one healthcare team to another. And then it's important when you have a change like this to actually schedule a care conference with the family, so that they can touch base with you. You can help alleviate their issues, and especially if something happens that's going to affect their original medical insult or treatment. Now, if you're starting a new team system, and I'm sure almost all of us are now locked into a computerized documentation system, is that you may even want to think about having a team note build, so that it's all in one place. Everybody goes in and puts their note in a certain section. This is for any of you out there that are listening to this that know me, you're probably chuckling now, because I am a person that knows my stuff, but I'm not necessarily computer savvy, and so I have much to say while I'm documenting, because it's not going in as smoothly and fastly as I would like. And then there's other hospital community-based therapy systems that may already have programs in place, and to see if there's anything being used in which you can develop a similar system or checkoff system. You may talk to a team in a nearby city at the same level of hospital you are, and they said, oh, well, we've been using this process for, I don't know, 5 years, and it's been working real well. And what you really want to do is have in your standardized team plan or documentation a place so that everyone knows what the dates are for the team, and the outsiders can put in, or they have the ability to add appointments, or there's a team key person that updates the follow-up system and or new therapy dates, so that that helps you when you're seeing the patient. Many of you probably through the years, if you've worked with a mom that has a handicapped child, or sometimes we work with foster care parents that take care of medically challenged children, they have a system down that would put much of our computerized systems to shame, because they have spreadsheets on dates and appointments and who sees what and what was changed. And this is really what I'm kind of advocating, so that everyone knows what's going on with the patient when you see them, especially if it's a new therapist, etc. Now, depending on your level of experience or how long you've been in the NICU, you may have a situation where you have one-of-a-kind medical issue. And what I'm going to use as my example is metabolic disease, where you'll have one person, I'm just going to say homocystinuria, and you've never treated one of those in your career, and there's other people out there that do. So I'm encouraging you to reach out to see if you can find somebody. Also with certain genetic conditions and abnormalities of development and organ issues, there's people out there that have more experience than you that may even be the national center or worldwide center for a treatment area, to call and see if you can't ask questions if there's a problem. And I always joke when somebody asks me a question, and I will tell, because we're a teaching hospital, one of the residents asked me a question, and I just joke and I said, well, it's a Google away to get input on therapy. However, I encourage you to make sure that you're using a bona fide medical source for the therapy, but there's lots of information you can access with your fingers on the computer almost immediately. Or a care center that treats for them, and then to call somebody there and say, this happened, this happened, this happened, do you have any advice for me? Then if you have a patient that has a condition that you're not really familiar with, or something that's going to be treated in the future, say a baby that's born that will have heart surgery, but the baby has to get a certain size before they go there, is to reach out to where this patient will go for consultation and any idea of therapy, or do they have anything to suggest, etc., so that you're giving as individualized care as possible to this patient and family's particular issue or condition.